Good morning. Glad that we could set this time to discuss matters health on Health Tuesday. I'm Regina Manyara, being the 9th day of January 2024. Suffice to say, Happy New Year. Glad to see you. Now, we're talking about health and we'd want to know, are we adequately treating chronic diseases in the country? This morning we're talking about breaking barriers in the treatment of chronic diseases, and joining me in studio is none other than a pioneer herself, that is Faith Okwuayo, yes, a medical research and subject matter expert. Good morning, Faith. Glad to have you on board.
Thank you for having me. Yes.
Good to have you. Happy New Year. Let's
Happy
start
New Year.
How's the year turning out for you?
It's turning good. It's starting loaded, so we are happy and excited to see what the healthcare space is going to bring for us. Yes.
Now, talking about the healthcare space, we're talking about chronic diseases in Kenya, but we often talk about chronic diseases in Kenya and use the term non-communicable diseases. Can we use them interchangeably, or what is the definitive, parity, so to speak, between non-communicable diseases and chronic diseases in the country?
So, Kenya happens to face a double burden of both communicable and non-communicable diseases at the same time. Communicable diseases are diseases that are infectious, meaning they can be transferred from one person to another. Therefore, non-communicable diseases are diseases that cannot be transmitted from one person to the next. However, there are some communicable diseases that are chronic, like HIV, like tuberculosis. So we cannot use non-communicable diseases and chronic diseases interchangeably, because some chronic diseases can actually be communicable. Yeah.
Thank you for that particular, explanation. We often find ourselves making that mistake. Now, non-communicable diseases, as we look at, the statistics that we have indicates that they represent a third of the deaths that we have and half of hospital admissions, and they have economic consequences. But for this morning and purposes of this conversation, we're talking about chronic diseases in Kenya. From where you sit in medical research, what is the prevalence rate at the moment?
Actually, I'm glad to say, apart from just being a medical researcher, I happen to be the chairperson of Chronic Disease Society of Kenya. So we are in a very good space to have the right data to estimate prevalence rates in Kenya. However, we cannot say the current prevalence rate definitely, because we infer this data from World Health Organization, which happily I've been part of some studies for World Health Organization. And right now we can look at chronic diseases in a segmented and targeted manner. We have diabetes, which is at 5% prevalence. Cancer, which is also growing, its prevalence in the double digits per annum, but right now it's at 2%. And then we have other chronic diseases like cardiovascular disease, which is the highest mortality rate disease, and it's also coming in at over 10%. So these numbers are growing, and we are still asking for Kenyans who suspect or are living with a chronic disease and they want to get registered. They can come and register with the Chronic Disease Society of Kenya, so that we can have these numbers jotted, so that we can have the data definite for the prevalence rates, which is very good for planning.
For planning purposes.
Yes.
But even before we get to planning, there's the issue of just what am I suffering from? And that's the question that even the Ministry of Health is actually grappling with, the issue and case of misdiagnosis. As you said, I don't know, I suspect I'm ill, but is it a chronic disease?
Yes.
From that particular aspect, the impact that misdiagnosis is having on the, cost-effective management strategies for chronic diseases, how do we address that?
Misdiagnosis is a very, very, very big burden. And it happens because we don't have direct access to specialty doctors in Kenya. The reason why we don't have direct access to specialty doctors in Kenya is because they are few. We have a little below 4,000 specialty doctors in Kenya against a population of 50 million Kenyans. So right now, we are trying to focus on primary healthcare coverage at the primary level, level 1, level 2, level 3 hospitals, so that we can strengthen and build capacity amongst our community-based health workers. And these are the ones who will now put us in the right referral pathway to get to the next general practitioner before you get a specialist. And also, diagnosis starts with lab work, life sciences, and imaging. So by the time you present any symptom, you need to be aware that this symptom is a risk factor of a chronic disease. And how do you know this? By interacting with your nurses and being very open in your communication. Like, some symptoms are very obvious. Can you imagine depression is a chronic illness.
Yes, under mental health.
Yes. And even obesity is a chronic illness. Alcoholism is a chronic illness. But these are risk factors we'll mostly bypass because you think you have to at least maybe have physical symptoms or altered body structure for you to seek medication. So anytime you feel depressed or you feel you're out of breath, you're going tired, you need to talk to your nurse or your next clinician so that they can advise you on how to triage and how to go to the lab and get checked. So we need to check for risk factors for metabolic syndrome. Even food addiction is a chronic illness. Yeah, because by the time you're addicted to food, you're already presenting with hyperinsulinemia. That is, your dopamine is trying to tell your body, I need sugar. And that is already the first metabolic syndrome, first sign of diabetes.
Now, Faith, what you have said there may actually just come as news to a majority of people, given that we are not sharing the information as we should. Now let's look at what the current interventions that have been made by government to raise awareness when it comes to those risk factors as well as chronic diseases in the country. Do you think we have done enough to pass that information to the public, sensitize the public in regard to matters of chronic diseases? As you've said, when you say we often assume you're feeling hungry, you want more sugar, it's just a day-to-day routine and such. But then do we have the adequate support to know that this is indeed a risk factor and I may actually be suffering from a chronic disease?
Thank you, Regina. And I like your question because the government has tried its best. However, the government and government institutions only access 35% of our patient population. So we have 65% of patient population that is relying on the private sector, that is relying on faith-based organizations. So we need to have a strong corporate strategy and a private sector that is very observant to the universal health coverage, that is embedding the universal health coverage stipulations in their policies so that they can make sure that every last Kenyan is affording healthcare without going so much into their pocket. So now I'm proposing like we work with Chronic Disease Society of Kenya, for example, which is a third party that can link patients to the right private sector facilities that have subsidized rate of diagnosis, subsidized rate of medication, because we need to achieve what we call healthcare equity. Because you find the inequality in healthcare is so high, even in the low and middle income communities. So the government can only reach so much of the population because 67% of healthcare is accessed through the private sector.
True. Thank you for those statistics. When looking now at 35%, that is what government can actually get into. Over the last few years, we've seen government work on having, universal health coverage, across board. And we have the Emergency Chronic and Critical Illness Fund. Now, what is your take on the budgetary allocation under the above? If we can only get to 35%, does it mean we need to invest more in as far as budgetary allocation is concerned for chronic diseases?
Of course, we need to invest more. The reason why we need to invest more, I will tell you a story, Regina. I happen to have been privileged to be a team leader of a research that was going on in sub-Saharan Africa. The research was convened by World Bank, and we were trying to get what is the level of access to essential drugs. Essential drugs means the drugs that must be taken, the first-line treatment drugs for patients, and how is the affordability rate even under universal health care coverage for patients in government institutions. And we still found that there's there's a high burden of unaffordability of these drugs. You'll find a drug that is worth 100 shillings, 150 shillings is still not affordable to a normal Kenyan. So we still need to support the government as the private sector by, first of all, partnering with faith-based organizations, partnering with Chronic Disease Society, partnering with bodies that subsidize medication and give access to the vulnerable and marginalized community. Now,
another intervention that government has come up with is trying to build capacity within NHIF. I'm sure you're alive to the fact that we just recently found out that there's been a scandal where now medical, or rather private health facilities have been, engaged in fraud, so to speak. Now, when we balance between what the role of the private sector is actually playing in this particular value chain vis-a-vis integrity, you see, that's another thing we need to balance. As you said, we need to have a private sector come on board, NGOs, as well as other private sectors. Then how do we balance? How do we strike the balance between the two? Integrity and ensuring that medical health care is affordable to a majority of Kenyans. Wanjiko, that is.
So we need to empower the patient. Once the patient knows what they are supposed to do, what is the treatment trajectory, they will know what to expect, and they will even know the cost implications. So they will have the right to query the institutions and follow up. And then if we can also, with technology, if we can institutionalize and also put everything in the system so that we have accountable systems that are reliable, and the patient can access their history and the follow-up, and even the claiming their insurance, they can see how it went. They can be able to query these things before they are forwarded. So I feel like the easiest way to combat fraud is to empower the patient so that the patient is also part of the process. Yeah.
Very well said. We are speaking to a pioneer in the value chain when it comes to trying to break the barriers on chronic diseases in the country. That is Faith here, who is saying that you as a patient, whether you're a patient or you're living with a patient who has a chronic disease, you need to know the growth, the treatment trajectory, what is required, what test comes after what are the general costing of this, so that you can eliminate fraud. This coming from the revelations that some medical private sector, or rather medical hospital service providers there, have been defrauding the government, especially where NHIF is concerned. So you need to know how the process of your treatment actually goes around, so that we eliminate fraud and increase capacity of this particular medical service providers, so to speak. We're talking about breaking barriers on treatment on chronic diseases. You can get in touch on our social media platforms. You can get us on X, that is at KBC Channel 1. My X handle is at Ray Manyara. Give us your feedback. What has been your experience when you're seeking this particular treatment? Do you want assistance? As we said, the private sector is also standing within this particular gap to ensure that medical services are affordable and accessible to a majority of Kenyans. That's our conversation this morning. On Twitter, what we refer to as X is at KBC Channel 1. Mine is at Ray Manyara. We'll be taking a quick breather before that, but before we get to our first breather, I would want to take back the conversation to our guest this morning. You said that, private sector, we need to empower, the person seeking treatment to know exactly what they're seeking treatment for. But then there's the issue of lack of information. Sensitization on, if today I walk into a hospital, you have to go to the triage. I think that's the first step. But then we find, especially in the devolved units, we do not have capacity, in our health facilities. As a private sector player, then how do we remedy this? How do we work together, private and government institutions, to ensure that when Wanjiko walks in seeking medical services, they get the right treatment for what is ailing them?
And if I focus on the chronic segment, allow me to start with the self-management aspect for patients. After post-diagnosis, after you've been diagnosed with, let's use diabetes for example, and then you're discharged to go home, the treatment does not end there. So of course you're going to go back for refills every single month, and before you do that, we need to position patients in a position, in a placement of power, where they can now be furnished with the right information to know what to expect when they go and queue in the hospitals. Our doctors are experiencing a lot of queue burden, because by the time they arrive at work at 8, they do not even get a break until they are leaving work, because the patient burden the queue is so long, and the patients need at least 1 hour of attendance. So if we empower the patient within our patient groups at the Chronic Disease Society, once we empower the patients, they go there already having handle half the problem of how to self-manage, how to stay compliant, stay stay adherent to treatment. By the time they're meeting the doctor, they don't have so much frustration and data silos of how they're supposed to manage themselves. That helps in reducing the queue burden. And that also helps in building capacity for the doctor to have a shorter period that they spend with the patient. Yeah, and the nurses also need to be empowered. The trainings need to go down to the nurses and the clinicians. By the time the patient is getting to the specialty, they have already been handled, and the specialty is just to prescribe the medication.
Indeed. That is Faith, our guest this morning. We're talking about breaking the barriers when it comes to matters of treatment of chronic diseases. Faith Okwisa there. We'll be taking a short break. Take this opportunity to actually get back to us on our social media platforms. Our X handle is at KBC Channel 1. Mine is at Ray Manyara. We're going to be sampling that at the course of this particular broadcast. We're talking about chronic diseases. As you seek this particular health services, what do you need to know? How do you better manage these diseases? We'll be taking that breather right about now. Good morning, this is KBC Channel 1 Health Tuesday. This morning we're talking about breaking barriers on treatment of chronic diseases in Kenya. And my guest is none other than Faith Okwisa, medical research and subject matter expert. Before we took a short break, we told you that we are open to your feedback in regard to this particular matter, and our X handle is at KBC Channel 1. Mine is at Ray Manyara. And one of our viewers is actually saying that they have learned something, that even their eating habits might actually be contributing to diabetes. So I'll want to take back that conversation to what we were talking about when you talk about these chronic diseases. Maybe you can just recap. I know we said that at the earliest, Faith. Maybe we can recap that now, given that it has drawn a lot of attention, that people do not think that alcoholism is actually, a chronic disease, and even obesity and such. Let's take it that down. Let's go down that road once more.
Yeah, thank you so much, Regina, and thanks to our viewer for noting that. Chronic diseases are diseases that are mostly lifestyle diseases, and mostly they affect your quality of life. And once you're diagnosed with a chronic disease, you have a treatment burden for the rest of your life, and you have a lifetime multimorbidity. Meaning, once you have one chronic illness, you could still have another and another. It doesn't end there. It keeps on affecting your body. So back to diabetes, for example. Diabetes is a very big area of focus because the prevalence rates in Kenya are going in the double digits. They are growing. In 2018, we were at 5%, and it's growing at 2% per annum. So you can imagine by now at what rate we are.
Wow. If
you see two people seated, one of them is likely to have metabolic syndrome.
Now, both of us are seated here. There's two of us here. Two of us here. Yes. So you're saying among us?
Yes, so now if you see the two of us seated, one of us highly likely, has a metabolic syndrome. And what is metabolic syndrome? Metabolic syndrome are risk factors that directly lead to diabetes. And diabetes is important because once you have diabetes, you can easily develop hypertension. It's so easy to develop cardiovascular disease. It's so easy to go ahead and develop cancer. Actually, 66% of cancers come from diabetes. And that comes also with metformin and medication and insulin. It's a whole story. So most of our diseases are informed by the gut and the microbiome in the gut. So that's why eating is very important. Once you're eating and you feel like you're craving sugar, you're craving processed food, you're craving everything sweet, just know that's a metabolic syndrome. You need to check your blood sugars. You need to go to your lab, your nearest lab. You need to check your insulin levels, because your insulin levels will inform you whether your diabetes is kicking in or not. And diabetes comes from insulin resistance. So you see, by the time you're diagnosed by diabetes, you've been living with it or the threat of it for 10 years. So once now people come to us at Chronic Disease Society, we are going to educate them and sensitize them about these things. And everybody knows somebody who has a chronic disease. I'm so sure everyone has lost a relative or somebody close to a chronic disease. And these chronic diseases, as much as we talk about them and talk about the prevalence, it's higher than we think. It's really higher than we think. And in sub-Saharan Africa, it's becoming a big burden because we've been focusing on the pandemics, we've been focusing on the infectious diseases while neglecting the diseases that are lifestyle, that are now here with us, and they're increasing the stresses of performance, and they're reducing our socioeconomic status and our quality of life. So yeah, diabetes is a very big area of focus, and we need to increase the grassroots campaigns to increase the diagnosis. Early diagnosis and early detection is very important because it reduces the treatment costs, reduces the treatment burden for the healthcare that is already overburdened. Yeah.
Now, I think you've actually picked up that from my, my checklist here as you're going down this particular conversation, where it has noted that, early detection has been identified as one of the key interventions in cost-effective treatment of chronic illnesses. But then how do we foster this? A majority of people only go, or rather seek medical services or medical attention when it is hurting. We walk in when, we can't sleep, we can't do this, we wait up until it actually hurts physically. But then how do we change the dynamics? As you said, by the time you're diagnosed with diabetes, it can take up to 10 years. That's a decade. You've lived with this situation for a while. How do we foster this? How do we have a mindset change when it comes to chronic diseases?
That's a good question. And I think we take it back to the people. Education. What we are doing here today, I love it because this platform is being accessed by many people across the country who may or may not know what chronic diseases are. But it starts with talking about it. Once someone feels uncomfortable, you don't have to get an acute syndrome or high fevers for you to seek medical attention. Even prevention is part of medical attention. So how do we now? We have to do routine checks, we have to do yearly checks, spot checks. You always have to just have a calendar for your health. And as you look at your nutrition, also look at your vitals. Go to the nearest laboratory, go to the nearest dispensary, talk to your nurses, talk to your clinicians, even before you think about talking to your specialists. If you feel uncomfortable, if you feel like maybe your energy levels are going down, anything that is out of the ordinary, seek medical attention in terms of just inquiring information, talking to third parties like Chronic Disease Society of Kenya, checking the symptoms. And there's technology. Artificial intelligence has come with a lot of solutions that can also ease the workload for doctors. Because once you can download apps like EDA, they're diagnostic apps, once you log in your symptoms, it can direct you to disease areas that you should be concerned about. And preventatively, then you start working backwards and reversing. Because most chronic diseases are reversible if detected early.
Reversible if detected early.
Yes.
Now, Faith, let's take it back. What did you say the app is about? Did you say EDA? EDA?
Yeah. ADA.
ADA.
Yes.
ADA. That's an AI that can help you,
yes.
Self-diagnose.
And we don't want to even get to a place where we now have to start treating diabetes, for example, or even cancer. I don't want to say cancer because cancer comes with a level of stigma and almost a very high mortality rate. So diabetes, which people feel like it's a comfortable disease, is a big burden, because when I was doing a study for Novo Nordisk, it's a European manufacturer of insulin, we came to discover some very big unmet needs and gaps in the treatment of diabetes. Because remember, in Africa, we are still fighting for pharmaceutical equity. We are still even fighting to have clinical trials done on our own genomic type, so that we can even have medications that are tailor-made for us. Yes. We still have a lot of wars to fight. So we do not want to get to a place where we are now handling a lot of burdens at the same time. So when I was doing the research for Novo Nordisk, there's a product called insulin. Many people are aware of it. It's when your body is extremely resistant to insulin and you have to use physical insulin to support metabolism for your sugars. So now, insulin is a cold chain product. What we mean by a cold chain product is it has to be stored at the temperatures of 2 degrees Celsius and 8 degrees Celsius. Many people who are using it know that it's a very high risk product that no one wants to handle because it can easily cause infections, it can lead to other problems. So imagine there's a person who has diabetes, they have to depend on insulin in rural-based areas. They don't even have electricity, they do not even have maybe a fridge. So how do you store this insulin? Of course, you'll buy insulin at a very high rate, transport it all the way, because transportation to the last mile delivery is still a burden, because how do you maintain the temperatures when you're not transporting it in a fridge? Yes. Yes, so you're using an ice pack. Then once you get home, that ice melts. What do? People dig up holes and bury the insulin in the soil. And then every single time, and you have to inject yourself 3 times a day, you have to go and dig and inject. Imagine what are the high what is the even probability
that it is not going to go bad,
even for the most careful person. So we don't want to get to that level where now we are dependent on medication when we are still even trying to get the right medication within Africa. So when it comes to data, we need to also be very vigilant, because research is what brings about development. So we are here as Chronic Disease Society to encourage people to bring their statistics to us, to register with us, so that we can now put them on the map for clinical trials.
Now, talking as a Chronic Disease Society now, is it open to anyone? Are there charges, for me to actually access your services? Because also we want to understand, as a society, how are you standing in this particular gap, linking maybe the one who is seeking medical services to the right service provider, and also that data and that research? How are you standing in that gap?
So we have a very good constitution at the Chronic Disease Society, and we have trustees and board members who are well experienced medical doctors, professors, and people who've been experiencing healthcare for a long time. So for you to be in touch with us, you can join as a member. Patients, anyone who's a patient, anyone who's sick, joins as a member for free. There are no charges that are attracting membership for patients, because we are institutionalizing help. We want to make help official, seeking help official, and to remove also the fear of costs, because we are already heavily saturated in costs from end to end right now, and debt is a burden everywhere. So we are trying to eliminate that level of costs by attracting people. Come for free, register with us, and tell us, hey, I feel like I have thyroid disease. I think I was diagnosed with cancer, but I've not been accessing treatment. I've been living with arthritis for a long time. So once you give us those statistics, then we place you in the right group, because there are different segmented patient groups. Within those right groups, you're going to get access now to a referral pathway. That referral pathway will lead you all the way to a specialist in an ethically observed manner. So we are within the guidelines of now directing patients to the right place. So we created this Chronic Disease Society so that patients can have a place to run to, which is a third-party place that we are doing this for patients full-time, because hospitals are already busy. You only go there if you're not in an emergency situation. You're actually put at the back of the queue. So you feel like I've not been heard, and you feel like there's some level of injustice. So we are now bringing back now a solution where you can come to us and get the right information and know where to go and seek the right treatment.
So do you have a website?
Yes, we have a website.
What's the website?
Which will I will give you to share at the end.
Yeah, okay, fine. So then we have a pool where those who are seeking treatment actually can come to and get better direction.
Yes.
Now, critics of the healthcare system, have said lack of integration as well as specialization is to blame to a large extent for a gap in the knowledge practice. What is your take on that?
I agree with the critics, and I also disagree with them.
Okay, let's hear it.
Because service integration is very complex. Because already specialty medicine is very complicated. It takes a doctor over 16 years of education, post-primary, another 16 years to become a specialty. And in between now we have registrars and students. So by the time you're becoming a specialist, let's say an interventional cardiologist, or you're becoming a rheumatologist, you've given it 16 years of study. And right now we have only 10 rheumatologists in Kenya, if we are talking about the numbers. We have less than 100 interventional cardiologists. We have less than 40 oncologists who deal with cancer. We have less than 50 endocrinologists. We have 365 physicians. So imagine this against the population of Kenya. How do we integrate specialty treatment? It's by training now the people at the bottom, training the first respondents who are dealing with patients. And once you go to the hospital, the nurse should be empowered to give you good advice and direction of how you will reach the specialty. Of course, because of the guidelines and the World Health Organization stipulations, you cannot just be pronounced diabetic by anybody. You have to go through the process, the right testing, the fasting sugars. You have to take your days, because you can also risk misdiagnosis, and then now you start medication and it takes you back. So service integration comes through a lot of partnerships, embracing technology, and information dissemination.
Now we'll be taking another breather, and I'm just going through our feedback here, and one of our viewers actually is asking about the AI app. Faith, maybe before you take that break, what it was, ADA?
It was ADA, yes. So once you have symptoms that are all over the place and it's been taking too long for you to get diagnosis, just go and key in all your symptoms in that app. They will direct you maybe to 2 or 3 disease areas. Now you can go and target your lab tests based on those predictions.
And on that note, we take a short break. We'll be back. Do not go away. Good morning. Thank you for keeping us company. Still speaking matters of chronic diseases and how to tackle the barriers therein. This morning is Health Tuesday. Thank you very much for your feedback, especially those who are watching from Vihiga there. And the Western region is going to also come up in this particular conversation, looking at the prevalence rate when it comes to some of the non-communicable diseases and chronic diseases, so to speak. We'll find out from our guest this morning, none other than Faith Okwisa-Okwaya, medical research and subject matter expert. Now, as we said, they're watching, they're saying they're watching, and we like that they're watching, so we are communicating. Now, before we actually took our break, we were talking about, services, how to seek them, what to know, empowering those who actually welcome the patients to the facilities. We're talking about the nurses and such before you seek specialized treatment. Government has been rolling out a series of interventions. One of them is a universal healthcare coverage. And we also have the emergency and chronic disease fund, a budgetary allocation to support treatment of chronic diseases. But then do you think that, under UHC, are we meeting our objectives when it comes to treatment of chronic diseases in the country?
UHC is an SDG, sorry. Allow me to use the full names. Universal Healthcare Coverage is a sustainable development goal convened by the United Nations in the year 2015, and it's SDG number 3. So, are we meeting it? No. The reason why we are not meeting it is because I already said government only has access to 35% because the government facilities can only service 35% of the population. So we still have 65% that are relying on the private sector. So the private sector needs to incorporate the UHC policy in their manifestos. They need to incorporate that in their treatment procedures so that no one person is being left behind. Even the people who come in without insurance, they should still consider that and subsidize the cost for them so that we are in tandem with the UHC. Yeah.
But then that would be quite something, given, private-run institutions are private-run, so to speak.
Yeah.
And given from where we sit in as far as an economy is concerned, we are more capitalist. So unless there's, it's not lack of capacity, I think it is the lack of willingness when it comes to, integration and universal health care delivery within the private sector. But that's a story for another day.
Yes.
Now let's talk about the cost of management,
Yes.
the cost of management of these chronic diseases, and it's one of the challenges when it comes to barriers, to chronic diseases. From where you sit, how can we make it more affordable, to manage these diseases? We are having them for a lifetime.
Yeah.
But how do we make it, or how do we enhance, our care to bring down the cost?
I feel like now we need to incorporate the private and public sector so that we can marry all our agendas and work together. This will help bring down the cost, because if more people, it's volume, it's called volume pricing. If more people are able to access these services, you still meet your margins, you still meet your profits as a private sector, so long as we are now able to cover all of them. The cost, there's a very high cost burden. The cost ranges from diagnosis to now consultation, to lab work, to treatment, to pharmaceutical prescriptions, and then now back again every month for refills. So the cost is extremely high, and I can even estimate for an average person living with diabetes, they don't use less than 20 to 30,000 per month. And for our average households, that's already over 60% of the budget. And most of these people who are having lifestyle diseases are our breadwinners. So how do we bring the cost down? Is through now empowerment, as I said, and self-management. Because now once we are able to get diagnosis early and bring down the cost by seeking treatment early, and also sometimes reversing the disease through the right education, the cost will considerably go down. Partnering with multinationals, partnering with private sector is also going to bring the cost down, and also informing policy where there's a price ceiling. So, you know, right now there's free pricing. You'd find some pharmaceutical companies even do 100% margins on their products. So if the government was able to bring a law that can bring down the margins to 12 to 15% or 12 to 30% maximum, then we'll be able to bring this pricing down. However, also this is a discussion, like you said, that is on a policy level
for another day. And I want to throw in another discussion here: the issue of insurance, private sought insurance. That's also quite something, quite the debate, because when you're seeking medical insurance, there's a different clause altogether for treatment of lifestyle diseases, or what we term as chronic diseases. Looking at the insurance value chain, you know, government has made its intervention through the NHIF, but then we still have the private sector that, you know, we have private underwriters when it comes to medical. I mean,
yeah, I get where you're going, and just to support you, because also during our research we check stakeholders across the board, and we've talked to a few insurers, and it's a very tough debate, because once you are diagnosed with a chronic illness, the insurance requires you to declare that beforehand while you're filling in. And mostly you end up doing a co-payment, which is still very strenuous for people living with chronic illnesses. And for some illnesses like arthritis, osteoporosis, the treatment costs are very high. Cancer is through the roof. And I thank the NHIF for also now bringing the cancer cost down, because chemotherapy up to is covered under the insurance. The National Insurance Fund, the NHIF, so that has brought things down. But the private sector was actually cashing a lot of money through chemotherapies and putting a lot of embargoes to treatment. So we need also to look in that and see, as Chronic Disease Society of Kenya, how can we bring down all the stakeholders to the board, and how can we have discussions and have compromises, because already you are downtrodden with a disease, it's already financially straining, there's a lot of crowdfunding going on, your relatives are already depleted. How do we now make sure that this person is able to afford? We need to start such discussions. That's why we are stepping in as third parties, Chronic Disease Society, whose our main mandate is just to fight for the patient, to support the patient, listen to the patient, and still go ahead and now lobby in the private sector and the third parties for them.
Yes, thorny issue, that insurance issue. You know, if you're asked to declare, then the premiums actually go higher. And
yes,
in the event, and actually it's if you get a chronic disease while you're still under that particular insurance, it becomes chaotic, because they argue that you knew beforehand. It's it's a marking.
You might not be able to get reimbursement.
True that. That's another conversation that is affecting cost and how we manage, or rather lower the cost of treatment when it comes to chronic and critical illnesses.
And that's why even UHC was put in place, because part of the characteristics of universal healthcare coverage is making sure that we can access primary healthcare, meaning not a lot of out-of-pocket expenditure. Yeah.
Now, when you also mentioned something that one of the interventions that you're actually recommending is, partnering with multinationals.
Yes.
And when you're talking about multinationals, I want to take you back to 2020, 2019. We all woke up to a pandemic that is COVID-19.
Yes.
Well, Africa was on the receiving end, so to speak, because of our lack of capacity when it came to handling the pandemic. Under the COVAX facility, we also got support from, multinationals. Let's say multinationals, they came together. First World came together, decided, this is a facility that can actually help Africa and Asia meet. But then there's something that you have mentioned, that we are still having that struggle, that medicine that comes into the country is not tweaked to our genome. And that's a problem when it comes to treatment, not just treatment of chronic diseases, but just treatment across board. As a fight that you're still having, and I think you are leading in this as the Chronic Disease Society of Kenya, what conversations should we be looking at, to change these dynamics? Especially, as you say, the pharmaceutical war, so to speak. We're yet to build our capacity locally. How do we work around that? Have medicine that is tailored to treat us, our genome. I'm sure it's going to mean more efficiency, but it is also capital intensive.
Yes. Thank you, Regina. And that question can be answered in two ways. Okay. Yes. So post-COVID, I was privileged enough to do a research for the Global Fund in Ethiopia, Kenya, and Uganda to check access to essential medicine for patients living with chronic illnesses and communicable diseases during Corona. During Corona, the pandemic took over. And of course, our institutions were already spread too thin. So someone who was already diabetic was told not to even go to the hospital. So if they had an emergency, they're stranded at home. And sorry, I hesitated because that's the time I lost my dad to cancer, because he was also battling diabetes, and then cancer came as a comorbidity. Because when you have a lifestyle disease, you are risking episodic or lifetime multimorbidity. So the morbidity for him was gallbladder cancer. Then he died from it because he could not access medication early. So back to my story. When I was doing the spot check post-COVID, we realized that 80% of the patients living with chronic illnesses could not access essential medicine or essential drugs or even essential healthcare during this period. Meaning Africa is not ready. We are not prepared to handle these burdens. So, yeah. Can you repeat the second part of the question?
The second, how do we now, what conversations should we have when it comes to the pharmaceutical wars that we're having? Because we do not have medicine that is tailored for our genome, such that treating these diseases, whether chronic or otherwise, is generic for us, but not tailored for us. How do we change that conversation?
Multinationals have also struggled positioning themselves in our market because there's a lot of competition with the generic drugs. Thanks for mentioning that. However, we, as Chronic Disease Society of Kenya, and I'm glad you asked, one of our mandates is to fight for pharmaceutical equity, and we are going to lobby so that clinical trials are done in Africa. They are done in Kenya. Our patient cohorts who are going to register with us are going to be able to be sampled and examined and given these drugs. Like there's a company called Organon. It's an American multinational that is very willing. Companies are very willing to work with African societies, but when they come down, they look for patient support programs. There's none. They look for institutionalized, registered boards that they can work with as third parties, because there are ethics in research. You cannot just go doing clinical trials. You have to work with a registered third-party body, and then you still have to work with specialties who are already overwhelmed and busy. So as Chronic Disease Society, we are going to help in recruitment processes and forward the names of our critical patients who need help, who need access to clinical trials and novel trials of treatments that are current, that are modern, so that they're handling, because cancer is curable. Most cancers are curable, but Africans succumb to it because research has not been done on us. So you find we are reacting differently to different types of chemotherapy because research has not been done for us. So we are going to actually fight for clinical trials to be done on our patients. That's why we are encouraging you to register with our body, to register so that you are counted in. And once research is done for us, then we start having our own solutions that are very impactful.
Now, on the other side of the coin, or rather, if we flip the coin, the question is, how safe am I undergoing, clinical testing? Because there's so much that has gone around saying, oh, you're going to be treated like a guinea pig. You do not know if this is going to exaggerate or exacerbate the disease that you're already handling. How safe are these clinical trials?
The safety standards are approved by FDA and WHO. Of course, we have regulatory bodies. And still, you cannot just go as a patient and walk in and get a clinical trial. You have to be under a specialty. You have to be under an institution or a clinic, which is now monitoring your vitals, monitoring your adverse effects. And they can never go too far, because once you are out of the limits, the study limits, they always take you back to the placebo. So there's always a very good control of the study. So it's very safe. And we need to debunk some of the things we'll do as Chronic Disease Society, is to debunk the myths. Because we have a lot of fear factors and some misinformation that goes around. So we need to just empower patients by getting them the right information, giving them clarity on many areas.
Misinformation, that is one of the other challenges that is actually affecting, clinical trials, or rather just moving forward when it comes to development, when it comes to matters of treatment. As you work towards closing this particular conversation, as a society, you have done numerous researches in regard to, where we are in terms of our capacity and what is currently prevalent and such. How does the future look like? Given the data and the research that you already have in the next 5 years as we are working towards Vision 2030?
With UHC,
yes,
I have hope. However, the mortality rate is growing. The cancer prevalence is growing more than we like, even as Africans, because we've started eating the processed food. We've started taking the vegetable oil, which there's also a lot of misinformation that is healthy, because industrialization goes up, processing goes up, carcinogenics are in our systems. So the mortality rates, the prevalence rates of chronic diseases are going up, and the projections for the next 20 years are not good. They are going to keep going up. And it's not totally bad. We are not totally doomed, because once we seek early help and we have all the right information, we can be able to curb this. We can be able to identify the drivers of growth and handle them before they happen. And yeah.
So the future doesn't look so... you have hope with the UHC, if it's actually, implemented as it, in its spirit.
Yes.
So to speak.
If we support it and we all come together, build partnerships, strengthen our systems, build capacity, we are going to succeed, because knowledge is power. Not knowing and realizing late when you have to handle it, and it's a must. That's what we are used to as our culture and as Africans, because we are socially engineered to delay. And that is what is hurting us. But once we are now empowered, we do research, we have our data, we have our numbers, we'll be able to plan, we'll be able to mitigate the risk factors, and we'll be able to reduce the prevalence of chronic diseases. But we have to start now.
Now let's look at an individual capacity. What advice would you give a person? We presume ourselves healthy until it hurts.
Yeah.
But then with this conversation that we've had for the last 1 hour or so, you have said that it doesn't have to hurt for you to have actually a disease. It can take up to 10 years. From an individual capacity, how do we build that capacity of a Regina and another Regina who is watching this particular show when it comes to matters of chronic diseases?
Self-management is part of healthcare. Let's not relinquish our healthcare just to medical practitioners. By the time we are getting to them, it's because we've delayed too long, especially when it comes to chronic illnesses. Because, for the top 3 chronic illnesses, like cardiovascular disease, myocardial infarction, is stroke and heart attack is very high. The rates of hyperlipidemia and high cholesterol are very high. The rate of high blood pressure is very high. Diabetes, high sugars. Diabetes is not diabetes when you have to use insulin. Diabetes is diabetes when you already have high insulin in your body, when you are already insulin resistant. When you are going to the gym and you are not able to lose weight, you should be concerned, because that means your metabolic syndrome is kicking in. When you're trying something and it's not working, when your body is not behaving and responding normally, that's the time you should be concerned. And that's now why we are in the self-management category. So at the point where you are doing self-management, have empowerment and be confident that you're going to succeed in reversing these things before they get too far. And We just need the right information before we get there, because some of these diseases, they brew in our bodies for 10, 15 years before now they hit us in our late life, late 60s, late 50s. Let me not quote an age because it's very varying.
Yes.
However, it starts when you start being uncomfortable, when you start realizing I need to do something. Don't delay, don't postpone self-management. Don't postpone seeking help. Don't postpone checking your vitals, going to the lab, getting checked, well woman, screening like we do pap smears for girls, yeah? Endometriosis also. When you have those period pains and you think, it's just period pains, let me take Buscopan. But maybe that's endometriosis brewing. Most women who go get fibrosis, endometriosis, they've been having it since they were teenagers. Because we are stigmatized to seek healthcare, we shrink in our own cocoons and we shy away. So I'm empowering you, I'm empowering everybody who is worried, and anybody is everybody. It could be anybody and everybody. Actually, everybody should just check their vitals, stay informed. Information is power, and just have self-management and preventive measures as the backbone of our healthcare.
I like how you've put it, but yeah, I like how you've put it. And I'm not going to do a bat on that, but I like how you've put it. Like, we do not have to wait until it hurts. It is okay to walk to a medical facility to just say, what? I just want to have my vitals checked. Against the devil's advocate term is that if you go seeking for it, you're definitely going to find it. But it is good. I think we need to have that mindset that, you know, you don't have to walk into hospital when you're actually very, very or acutely sick to seek medical. It's good to have your vitals checked.
Yeah, and it's not all bad. I don't want to discourage anybody. Just start with your water. Just take water. And the simplest hack is, if you're 100 kgs, multiply that by 3%. Always take 3 liters of water and above every day. So whatever your body weight is, multiply it by 3% and take that amount of water every day. Now, next step is just take walks. Take water and walk. Those two alone can save your life and even increase your lifespan by 20 years. We don't even have to go for the most complicated interventions. Just taking water and walking is enough to kickstart your healthcare journey. And chronic illness, as I repeat, is a lifestyle, or is caused by lifestyle. So when you take water and walk, you're delaying the chronic illnesses, because somehow 50% of the population succumbs to chronic illness, and that's data from World Health Organization. We cannot argue with the numbers. So one, as I said,
50,
2 people.
Yeah, 2 people.
One of you is going to die.
We're already seated here with 2 people. And if you're going to do the statistics via our 2019 census, it shows that Kenya has a population of around 50 million.
Yeah.
So 50%, 25%, you're likely to succumb to lifestyle diseases, chronic diseases.
Yes.
So we take water and walk.
Yes.
Take water and walk.
And then go see your nearest healthcare practitioner. Ask them questions, even for no reason. Even if you're okay, ask them questions, they will direct you.
I hope they'll be open to listen to these questions, and they'll not have had the queue burden, you know, that kept them in the office for long. So before we come to a close, the Chronic Society of Kenya is open to you and I, and we had mentioned that there is a website where you can seek help, and this is also in addition to that particular AI that is ADA, that is going to help you in one way or another look at the areas of focus where you're concerned in terms of your health. That AI app is ADA. Put in your diagnosis or how you're feeling there. It's going to give you a guideline to, you know, areas that you need to put emphasis on. And if you were wondering about how to get help, if you're already seeking treatment for chronic disease, this is a society where people have come in together to try and direct each other on where they can seek suitable, specialized care for what it is, what chronic disease that they're dealing with. My guest this morning, Faith, kindly give us that website so that our viewers can actually hear it once again.
Okay, our website is www.cds-africa.org.
Take that again,
www.cds-africa.org.
Indeed. So if you were seeking or rather you're seeking, services, or you're getting treatment for chronic diseases, this is a website where you can log in, get assistance to better treatment, to lower the cost of management of these chronic diseases. These are lifetime diseases. If you're already diagnosed and you're seeking treatment, this is something that you live with for the rest of your life. There's no need for stigma. Help is always available. The website, once again, is www.cds-africa.org. Our guest this morning has been other than Faith Okwesa Okwaya, who is a medical research and subject matter expert. And this morning on Health Tuesday, we have been discussing, breaking the barriers to treatment of chronic diseases in Kenya. The statistics may appear grim, given that 50% of our Kenyan population is set to succumb to chronic diseases. And the personal advice from our guest this morning, that is Faith, she said, your weight, do 3% of your weight. For example, if you're weighing 100, that means 3% of that is 3
liters.
3 liters of water, and walk. That way, you might just as well delay or totally avoid, contracting a chronic disease. I've been your host, Regina Manyara. I would want to wish you the good viewership going forward. My colleague Ben Troy enjoys on the other side of the studio. He's going to be taking you through News Check this Tuesday, being back to school. This week we're going to be seeing a lot of back to school there. Just yesterday we had the KCSE results there announced by Education Cabinet Secretary Ezekiel Mashogu, and there's a lot of conversation and debate around what has been happening in the education sector all the way from December and November. There were also claims that have been made on social media platforms in regard to a change of marks, and maybe, aligned towards, having that particular portal being hacked. Their parents have come up and said that the first time they sent the message, they got different results. Much later in the night, when they keyed in the same, they got different results. Well, we'll be keeping tabs on that. I'm sure that's a conversation that is going to be had in detail by my colleague Ben Troinger, who's coming up for News Check. And talking about those who did well, would want to recognize Miguel Oyomo from Moi High School, Kabarak, who scored a mean grade A. This is an SMS that we have received direct from our social media platforms there. Congratulations, Miguel, there for doing well in school, and all those who did their best there. Remember, also we have seen a trajectory of students who are opting not to go to university, but also just seek, to build their capacity within the polytechnics. That is a conversation that is going to be going on News Check with none other than Ben Troy. We have been talking about matters of breaking barriers to treatment of chronic diseases with none other than Faith Okwesa Okwaya. And I'm Regina Manyara. I bid you a good day.